So I'm Anna. I'm one of the PGY4 residents. Then that's Jomar. We have Jason coming along, and Mike Simon, who's our current pager intern, is unfortunately busy paging. So he may come a little bit later, but I'll go ahead and get us started. We can make this like super informal, and you guys can just please, like, there are no stupid questions or comments, because I remember being an M1 and like it's all about pattern recognition. So this is just a good opportunity for you to get used to just like seeing what bones look like on X-ray. And if you have any questions at all, please just like shout them out. So this first patient is a 36-year-old female. She fell down the stairs, I believe, and she sustained this left humeral shaft fracture. It's pretty just mid shaft, and probably like oblique is how I would describe it. This is the AP view on the left, and then a scapular Y view sort of on the right side image. So she was seen and placed into a coaptation splint, which is a splint that kind of goes above the shoulder, and then it wraps all the way around, and then sort of into the axilla, and as well as a cuff and a collar. So that is sort of like, it's like a sling, but it wraps onto your wrist rather than your elbow, because we like to use gravity to allow this fracture to stay at a good length. So it looks kind of silly because we have to make it in the ED ourselves. They have nicer ones that you can buy like off Amazon or in the office, but we basically will wrap like soft roll inside of this like stockinette, which is like a big long cotton stocking, and then wrap it around their neck for support, and then their wrist, and which is like splinted. And that just sort of keeps their arm more comfortable and like sort of adducted to their body.
So Anna, could you go back and just explain what an AP and a scapular Y is?
So AP is,
just show us all the little different things that we're looking at there on the left and right.
Sure. So an AP is just like anterior posterior view. So that's just like looking from like I'm looking at your anterior to posterior right now. Like if I were to shoot a beam like this, that would be your AP view. A scapular Y is a type of lateral, so sort of looking at your side, but it's a lateral directly through the scapula. We call it a scapular Y because if you're like looking at the scapula right here, it's like, I can't reach it all. I was really dyslexic. Can you see my mouse? Oh, there we go. That might be easier. Oh, wait a minute. There you go. So if you look on the lateral, it's called a scapular Y because you can see like the Y shape of the scapula. So that's why it's called that. And that's just, you just need like orthogonal views is what people always say. Like one X-ray is no X-rays. In order to really like visualize a bone and know the pattern, you need at least two views that are orthogonal to each other to sort of build this three-dimensional concept in your head.
So what is orthogonal?
Orthogonal is like perpendicular. So like instead of looking like if this is your, like I'm looking at you like this, I'm clicking on you because I met you today. So I'm looking at you like this, and then I'm also looking at you like this. And so you put those two together to sort of build this three-dimensional picture in your head. You guys haven't had like anatomy, right? You guys are mostly ones, twos. You've what? Oh, okay. So some other things that you can look at on this X-ray, like obviously this is these are X-rays dedicated to the humerus, and I know that just because I can see the whole humerus bone. But other things that you want to look at when you get called for these types of injuries, they say like, oh, someone has like left arm deformity or like left arm pain. You can sort of see on these images. You want to look proximally, meaning like closer to your body. So that's the shoulder. You can see the distal end of the clavicle, which is right here. And then it meets, this is the AC joint right here. AC meaning acromion, which is this bone, and that kind of wraps around. That's part of the scapula. And then C meaning clavicle. So you're looking at this joint. So you also, you're also just sort of looking up globally. Like obviously you see the fracture there, but you also want to make sure that there's no other injuries that could be going along with this fracture pattern. Sometimes you see people with clavicles and, humeral shaft fractures. And then distally, this is the distal humerus, and you can kind of see this is like an oblique, crappy view of the elbow, but you're also just looking for anything crazy that looks down here. It looks fine. And you can see this is an actual lateral of the elbow. And you can see that, this is the radius right here, which has sort of this like sort of plate looking appearance. And that looks congruent, meaning it's matching the contour of the distal humerus here. And this is the proximal part of the ulna called the olecranon. And that also looks fine. So I really just see this mid-shaft humeral shaft fracture on these images. And oftentimes, especially in younger, like buffer, I think men, these can be very, very deformed. And so it'll look very varus, which means like V-shaped here. So it'll be poking out like that. And this wasn't the case for her. But the force that's pulling it, that is the deltoid. So you have to fight the deltoid when you're trying to splint this.
So just to stop you one second, you didn't know if it was a man or a woman, what may give you indication as to the gender of the patient based on that rating?
I assume you're not asking me.
I'm not asking
okay.
I'm posing it to any students that are looking here. Yeah. So yeah, I mean, you're taking everything into account. So, and I got that right. That the underwire of the rock can be seen right medial to
And body habitus, just in general, man or woman, can be a very difficult thing to overcome when you're thinking about how you're going to splint somebody. People who are more like have a larger body habitus and have more going on like over here, you have to fight that to sort of because that's going to be creating this varus deformity in the arm, and you have to fight that. Luckily not in this patient's case, because it looks relatively minimally displaced, and she doesn't look too large. But these also things that you note when you see these images, you like before you even see the patient, you're like, oh god, this is going to be like hard.
Anna, are you able to hear me?
Yes.
Hey.
Hi, Dr. Mennona.
Hi guys. So I'm Steve Mennona. I graduated from Robert Wood a couple of years ago. I'm going to be joining practice with Dr. Cott. So Anna did a great job explaining this. So kind of like what I'm sure what's going through some of your heads right now is, how do I get from where I am to being as knowledgeable as Dr. Green, who just explained everything. So as an orthopedic resident, you go on this journey where first you're looking at an x-ray and you have to be able to identify what you're looking at. So you identify the anatomy. And then when you see an x-ray like this, you look at it and you have to figure out, A, what am I looking at? B, what's wrong? So Anna described, this mid-shaft, slightly oblique humeral shaft fracture. And that's kind of how we talk in orthopedic terms. And then the third question is, how do we treat it? How did this person that comes into the ER, they come in, and they're hurt. How do you diagnose it? Just like you would diagnose anything in medicine, you have your differential, and then what's your treatment? And then, in orthopedics, there's really, if you want to boil it down, there's two treatments. One is to not operate, and the other one is to operate. And then once you figure out that, then as you get more advanced, we have techniques that we use to fix these fractures to get people back to what they were doing, whether it be back to an activity of using their arms or able to walk again, or to improve their life. This is just fracture care, but that's kind of the overview of what you do as an orthopedic surgeon, whether this is trauma, but that's kind of that's the overview.
So the other thing, just that Dr. Mennona brought up a good point, is like when you're deciding whether something's operative or non-operative, we're treating non-operatively. Like I splinted it. We splint a lot of things that we're going to treat operatively too, but these types of fractures can heal very well in a functional position when treated non-operatively. Now it's a little bit angulated. If you look at, this isn't a scapular Y view. This is called a transthoracic lateral, which is like transthoracic, just meaning they basically shoot like through your thorax. And so we make them like hold a bar up, they take a deep breath to inflate the lungs. And then their arm is like by their side. So they just like shoot through. Because it's hard to like get a real lateral where you're like moving their arm up if it's broken and there's all this padding in there. But you can still see it's like a little gapped anteriorly, and it's angulated a little bit. The good thing about humeral shaft fractures is that you don't really need it to heal like anatomic, meaning like the way you were born. When we treat a lot of things operatively, one of the reasons why we treat a lot of things operatively is because we're trying to make it anatomic, and there are certain bones that need to be anatomic, which we'll get to later, and there are certain areas that need to be anatomic, and so that's like inside of the joint. So like if this were in the shoulder and there was a crack that like went into where the glenoid like met the humeral head, and that's an area where it sees a lot of motion, that needs to be anatomic. So that usually means that you have to do surgery. Or if this were in the distal humerus, like where the bones meet in the elbow, that will often needs to be treated surgically to recreate your anatomic, the way you were born. But something like a humeral shaft fracture, doesn't need to heal 100% anatomically. There's certain degrees, which I don't think is necessarily important for you to know at this point, but that are acceptable, so that if you go over that threshold, it won't heal in a way that's functional for people or will limit their functionality. And so we'll, treat them operatively in that circumstance. But this one's like or minimally displaced. It's a little angulated, but definitely within like an acceptable criteria range. And it's not inside of a joint. And so this will probably heal just fine. What happens is they get put in a splint for like a week until they get seen in the office. They're really, really, really swollen when you first see them, like really swollen. And the swelling after a few days will go down to their hand. And sometimes they call and they're like, oh my God, my hand is swollen. But they do really well. You get them in a brace, which like wraps circumferentially around the humerus and sort of compresses it and keeps it straight. And the union rates are really high for treating this specific type of fracture in a brace. So non-surgery. Does anyone have any questions on that case? It's okay if you don't. So we'll keep going. If you have any questions, just shout them out. So this is a 37-year-old gentleman who I believe fell off of a height. And he had this both bone forearm fracture. We'll typically just abbreviate these both bone forearms, just meaning both of the bones in your forearm are broken. So both the radius and the ulna. On the left, you'll see an AP view. So again, that's the anterior posterior view. That's basically your arms out on a table like that, and they're shooting down. And then a lateral view. So they sort of rotate the arm somehow. Sometimes their patients are really painful, so the injury films are not awesome, but they basically sort of try to rotate the arm. It should be like this, where your arm is like above on a table and your elbows like curved like this and your thumb's pointing up, but that's usually not the case when someone's injured and like ow and screaming at the x-ray tech. Here's the radius. So that's the sort of larger wrist bone down here. And then you can see sort of mid shaft, there's this transverse fracture. This goes all the way up into articulate with the distal humerus. And then next to it is its partner, the ulna, which also is articulating with the humerus. And then sort of has this like short oblique fracture in the mid shaft, meaning the middle of the ulna. And then it ends over here. And then sort of the lateral, I think you see the similar thing. But the other thing you have to look at when you see these injuries, like I was sort of alluding to earlier, is that you want to look at the joint above and below. We're getting sort of a glimpse at the elbow joint here, which looks pretty congruent. The radius is sort of, well aligned with the distal articular surface of the distal humerus. And then the same thing with the ulna. This contour seems to match. And it's harder to see on this view, but I don't see anything sort of glaring out at me. So what do we think? Surgery or no surgery?
Surgery.
Nice. I like that. Surgery. So first it was splinted because we don't just leave people with floppy arms. And then he was admitted and we did an open reduction, internal fixation of both the radius and the ulna. So I talked about earlier, so the humeral shaft, we did not treat with surgery, but this one is similar. It's just in two different bones. But we treated it with surgery. And I think it's important when I sort of talked to you about earlier, the humerus, there's a lot of, degrees of freedom. But in the radius, you really do need to recreate the anatomic alignment, because the radius and the ulna sort of do act as a joint. Because if you think about it, when you have forearm rotation, supination and pronation, your radius is really rotating around so that it kind of is a joint. Like it's not an articulating joint where the fracture is, but it still acts sort of like where two bones meet and move around each other. So it is really important to recreate the anatomic alignment of the radius and the ulna in this sense. Oh, so what is an open reduction? So as opposed to a closed reduction, closed just means we don't make any incisions. Like we don't poke, we literally just like manipulate the body as we see it. An open reduction means we make an incision and we look at the two ends and we put them where they belong. And then internal fixation, meaning we fix it internally, versus external fixation, which I believe some other people may be showing, which is putting the metal on the outside of the skin to fix it externally in place. Any other questions?
Do the plates come out, or are they permanent?
So typically these ones stay in forever. There are circumstances where people plan to remove them, especially if they're causing problems. Like Sometimes the ulnar plate, because if you think about it, your skin is so thin here. On really skinny patients, I think people can sometimes feel that or be irritated by it. The radius plate is volarly. So if you're like putting your palm up, volar is this front surface. And so there's a lot more muscle mass there if you sort of feel your body there. So that tends to be less prominent. It doesn't usually cause as many issues. But for the most part, we tell people, mature patients who have this type of hardware placed, that they're likely going to have it in forever, unless there's always some like other special circumstances. But for the most part, these plates stay in forever.
Are those plates just on there, or are they like pushing against the fracture?
Great question. So that's a big topic. So you guys may or may not have heard of like this. These are special plates called LCP plates, DC LCP plates, which basically means that like if you look at the holes in the plates, like if you imagine plates which are rectangular, let's see if I can make this like really M1 level. Within a hole, if you look at the hole, it doesn't look like just a straight up circle. It's like oblong. So if you put the screw on the far end, so usually you put the fracture in the middle of the plate, and then you want at least 3 screws on both sides just for strength purposes. If you put the screws on the eccentric side, so that means the outer side of the oblong hole, and you put them down, that tends to this is like Orthopaedics. Is this Blackboard? Okay. Okay, good. I'm really bad at drawing. Okay, so let's do this.
Hey, Anna, if you want, what might actually be a little bit easier is I just Googled compression plating, and you could just
I
share.
love that. Thank you, Mennona.
Yeah. Okay, hold on one second here.
My drawing was going really well though.
All right, so it says you can't start screen share while the other participant is sharing.
Oh, let me stop share. Go for it.
Let's try again now. All right, so let's do this. Hopefully I don't have anything embarrassing up on my computer. Okay. So let's do this over here. Okay. So if you look over here, I think this will, nope, let's get rid of, you guys can see what's going on, right?
Yeah.
Okay. So basically what Dr. Green was saying, see if we can zoom in here. Okay. So basically here's the fracture. You can see my cursor, right?
Yeah.
Okay. So here's the fracture. That's bad. Bone's broken, right? You do your surgical approach, and that's part of it. So Dr. Green, if I were to say, do a volar Henry approach to the radius, Dr. Green would know. You basically have to be an expert in anatomy, and she would know where to place your incision, and then what muscles you're going to encounter, what nerves, what arteries, how to move them, and all that stuff. That's part of being an orthopedic surgeon. But after doing her approach, that's the first part of the open reduction, she would encounter the bone. We would use reduction techniques to bring the bones together without really damaging everything else. And then you would put the plate down. The first screw would go in like this, and that's a neutral screw. And then you could see how these holes here, they're kind of sloped. If everyone can see that. I can't see everyone nodding, but basically what's going to happen is the screw's going to go down, and this screw head is kind of sloped as well. And as the screw goes in, it's going to push the plate this way, and since the plate and this bone are united, the fractures, the bone is going to move that way as well. Are people nodding like they're kind of understand?
Yeah, I think they get it. So yeah, he's basically saying like, so if you put it on the outer sides, it's called like eccentric placement of the screw, eccentric as opposed to like concentric. So out on the outside, and it's going to slide down that ramp and then pull the fracture together. So it's putting it in compression mode where you're compressing through the fracture site, which is a great technique to do in these like especially transverse fractures where it's just like, or like oblique, where you can just sort of align them and you want to just squish them together.
Let's see.
Are you done sharing or?
Oh, well, if you want, I mean, I have, if you want, I can, I don't want to steal your thunder, but I can also show some stuff if you want. It's up to you.
It's totally up to you, Dr. Mennona. You're the boss.
Oh, that's.
All right, I'll show some stuff. Sounds good.
So,
Okay, whatever. I don't care. All right.
yeah, up to you guys. Yeah, why not? Okay.
We're booting you, Mennona. Sorry.
Yeah, there you go.
How do I make this work? Let's go to. Hi, Joe Maher, one of the ortho residents, PGY3. No one was here when I was an intern. You may recognize some of these fractures. They're from my intern year.
Bad boy, proud of you.
Absolutely. All right. That does look good. See that. Okay. Hopefully these animations play. So, I think, do I do screen 2 or just my screen? It's kind of the same, right? Because it's duplicating. Okay, so Aryee, PGY3, tail of 2 hips. We're gonna do we're gonna talk about proximal femur fractures, so fractures around the hip and the most northern part, or the part of the part of your femur or thigh bone that's closest to your pelvis. So right, the femoral head, neck, and just below it. The first thing I'll do is try and find where the mouse is on the screen. Am I going crazy? Can anyone see it?
Oh, I can see where you're.
Yeah, right, same. Oh, wait. Okay. Why was it disappearing? Okay. So the first thing I think we should talk about sort of are the basics of sort of what it is we're dealing with. So I can see there's some partially outlined parts of this X-ray, which tells you that my animations may be crummy. So first things first, I gave it away. This is an X-ray. Can anyone tell me, is this a lateral, an AP, an oblique? AP, right? Front to back view of the body part. The hip, pelvis, right? So the pelvis in this case is what we're looking at. Does anyone want to hazard a guess as to some of the structures that may be highlighted here? Some of the things that you may see on an AP, a common AP of the pelvis. Acetabulum, all right, so that's in red. Femoral neck, okay, that's there. Trochanter, so greater and lesser grade. There's also, right, the entire pelvis, right, the ilium, the ischium, the pubis, the pubic ramus, that's what's highlighted. I think these all, right, so plain radiograph, X-ray, AP pelvis. Oh, shoot. What side is this? So what side is what? Oh, yeah, nice. I didn't see it. L is the left side, right? So it's kind of backwards for you as you're looking. So that the what happens in an AP is, you know, the flat plate is behind you and you shoot the radiograph from the front and it captures that image, and so everything's sort of reversed. So on your left side is actually on your right side, and then here's some stuff. So ilium. I was supposed to like coolly like draw it around. It doesn't do that. I think this is like an old like PowerPoint version, I think. So femoral head, neck, greater trochanter in black, lesser in green, right? Ischium in that goldish color, starry color, ilium. Okay, so anatomy. I think we just went over essentially all of the things that all of the bony structures, and then there are regions, right? So there's sort of let's see, this region here is between the greater and the lesser trochanter, so we call it the right, in between trochanteric region of the proximal femur. Here's the head, the femoral head, and kind of right, that line below is called, I guess we call it subcapital, or just below the head, and then below that femoral neck. And so all of that is the neck of the femur. So these osseous landmarks are important for us because they help us decide, well, one, they tell us what's going on with the patient, so we can tell them you have blank. And then we can tell them, then that helps to inform us on how we're going to treat these patients. Going from here, blood supply, anatomy. So probably one of the more important things in our fractures when we're treating fractures in the peritroch or proximal femoral area is we need to understand, or what becomes very important is understanding of sort of the blood supply to the region and understanding how the blood feeds the areas and where our fractures lie and how that affects how we can treat certain fractures. So in this case, the femoral or common iliacs up here, and they come external, internal, and this would be the external, and then comes down, and you have the femoral artery here, and then this one is the femoral artery common, and then the common femoral artery, sorry, and then your profunda or deep femoral artery, and that gives off two vessels, the names of which are unimportant, but I think what's important to understand is that there's very limited blood supply going up to the neck of the femur. So when we have fractures in this area, you can see my cursor, in this area, the important thing to understand is that there's a tenuous blood supply here. I'll say that again at some point, and that'll become relevant because we'll see fractures that look similar, or at least in a similar area, and we'll treat them differently because of that. So blood supply, tenuous, okay? And then, let's see, what is this gonna be? Oh, right, okay, so again, there's another bit of important anatomy. So we went over the osseous anatomy. We won't talk too much about muscular anatomy. Deforming forces aren't relevant, at least for this topic. But what we will talk about is the joint here. So does everyone know? Anyone want to tell me what sort of envelops joints in our body? Does that sort of make sense? Is that like a concept that makes sense? The capsule. So there's always soft tissue that covers our joints, right? So over our knee, there's a capsule, an ankle, there's a capsule, and over the hip as well, there's a capsule, right? So Dr. Green, I think Dr. Green, Anna spoke a little bit earlier about sort of what you need to do when you're dealing with fractures in a joint versus fractures in the diaphysis or the central part of a long bone. And so this is a fracture around a joint. And so it's important for us to understand the capsule. So the capsule of the hip looks something like this. It's not that color usually, or there's a problem, but essentially it's here. So we can see, guess what I'm thinking. So this part of the proximal femur is what we call intracapsular, or within the capsule. And then out here is extracapsular, or outside of the capsule. That becomes important for us as well, because we'll start to combine some of our topics from before, or our thinking from before, so about the regional anatomy, so the inner trove, the femoral neck, the femoral head, right? And then we'll talk about the blood supply and it being tenuous, and then we'll put that together with understanding of the capsule and the intracapsular and the extracapsular, and that'll sort of help us to figure out why it is we treat certain fractures the way we treat them. And an important thing to understand about the capsule or the intracapsular environment is that it is not, it's hostile to fracture healing. So fractures don't do terribly well healing on the inside of the capsule. So that's one way to sort of to think of. They can heal, but it's less likely especially if there's significant displacement or disruption in a fracture. So we know the anatomy, we know the capsule, we know the vessels. Okay. Oh, right. I did that too. So this shows you sort of that vascular relationships, right? So all of those vessels are coming up and feeding that femoral neck, and it's all in this capsular. So this sort of, remember this image in your mind's eye, because I don't think I drew it again later on in our presentation as we're thinking about why it is we're gonna treat one thing the way we treat it. All right, so things inside the capsule in general, we'll say don't really heal. Things outside the capsule heal. So Oh, I think this is important. So this may start getting a little bit, but I think this is one way. So just like Anna was describing some of her fractures as oblique or transverse or displaced or non-displaced, the way that we think of fractures in the femoral neck and in this proximal femur in that femoral neck region, we classify them based on how much they're displaced and how much of a fracture there is. So the higher, most classification systems, the higher up you are in the classification system, the worse, quote unquote, the fracture is. So in a Garden, whoever Dr. Garden was, he decided that Garden 1 means a fracture that is incomplete. So it's not all the way through both cortices, as you can see, and it is it's displaced, but it's displaced in the in a position that makes the hip or the proximal femur more stable. Okay, and I'll sort of try to explain that as we go down the fracture classification. In Garden 2, we have one that's complete, but it's not displaced, right? It's like there's just a line through. It hasn't moved. All those little blue lines are still in continuity. And then in Garden 3, we have something that's incomplete and and partially displaced. So it's separate, but there's still some cortical contact. We can see though that those blue lines, they don't line up very well. And the importance of that, just again, I digress, is understanding the way the forces are transmitted from the body through the pelvis into the femoral head, and then through to the neck, and then through to the shaft. If you have forces going like this, right, you may understand, or it may make sense in your mind's eye that this would tend to gap if I put a weight here, right? It'd be unbalanced like a seesaw. And then Garden 4, so it's completely displaced. All hell's broken loose. We don't know what to do with this. So remember those things. Okay, a tale of two hips. All right, so these are both 84-year-old females with left femoral neck fractures. Okay, so does anyone want to hazard, I guess, or talk to me about maybe where they see the fractures on each one? Is there a pointer up here? Just point from down there. No. All right, Andrew, you're up. It's you. Come to us. Okay. All right, I see a lot of gaps here. Okay. Yeah, right. So like kind of in that where it'd be femoral neck, right? So this, right? So I put these up on purpose beside each other, right? This looks nothing like this, right? This one is the bad one. And so the fracture is right around here, and I'll draw it out in another. But how about this one? Yeah, kind of tougher to see, right? So the fracture is here, and it's drawn out. And again, right, you see along the femoral neck here, there's this nice, continuous line. You can see that line is broken here. And then the head almost sits down in a funny way, almost like Garden 1, maybe, right? So it sort of sits in what we call valgus. Okay, so femoral neck fracture. Here it is. So those are the two ends of the fracture. And so how do we treat this? We spoke about intracapsular fractures and extracapsular fractures. So is intracapsular or extracapsular? Intracapsular. Okay, so does it have a good blood supply or is it tenuous? It's tenuous. Okay, and then is this high Garden classification or low Garden classification? Low, right? Okay, low. So we treat it by trying to help make this fracture heal. What he just said, they don't heal, intracapsular can heal. I know, sorry. So what has been found is that in fractures that are relatively non-displaced in the femoral neck or displaced into what we call valgus in a more stable position for the head, you can treat them with repair, so screws, usually 3 screws that are placed into the femoral neck and sort of an inverted triangle position configuration. So what we're seeing is an AP or a frontal view of the hip here. So there are 1, 2, 3 screws, and then a lateral. So the way that you shoot it in the OR is sort of from here. So you get a lateral of the hip, and then you're looking at it and you see the 3 screws that way. And it's the post-op. Why do they? Oh, you mean like there are not a lot of threads, right? So right, screws, we think of having threads all the way across. So what would be the point of having screws with only some of the threads? Yeah, cheap, right? full screws, fully threaded screws are expensive. In fact, these are more expensive. So the reason we have a partially threaded screw is you have to start thinking about that, ask you to start understanding some of the rationale for understanding what's called lagging and trying to get compression at your fracture site. So the shortest way I can think of explaining it is when you have to drill a hole, right? So there's not just a pathway for these screws there, right? You weren't born with that. We drilled holes, for example, for this screw here, okay? And then the hole that you drill is inner diameter, outer diameter. So it's about the thickness of from here to here. So the thickness of the screw, the bare screw, okay, but a little bit thinner than the threads, okay? And so what happens is all of this part of the screw isn't what we call biting or purchasing the bone. The only part that is purchasing is here, okay? So that's the only part that has threads that can hold on to the bone. And so what happens is this essentially, the top part of our fracture here, so the femoral head, okay, we have purchase there, no purchase here, and then the femur, and then so what would happen, or what you expect to happen, is if you kept dragging the screw, right, the screw would just keep going on and on and on and on and out of the into the pelvis, into a bad place. But what happens is you have the head of our screw here that can't get through the cortex because it's also bigger than the it's bigger than the hole that you drilled. And so what happens is you pull the screw and the screw wants to move forward, but the head blocks it. And so this whole area, proximal femoral area, the distal part of the fracture moves upwards, or I guess you can think of it as pulling the femoral head. Either way, it allows for compression. So you get some, it resists kind of that displacement. So that's a way to think of it.
So Joe, just to take you back a little bit.
Yeah.
This X-ray didn't walk into the emergency room with patient.
Yeah.
So can you just explain to the students, your involvement with this patient? If it's somewhat fictitious, but from the moment you met them, maybe what happened even before they came to the ER up until the time that they left the hospital.
Yeah, long story. The typical mode. So typically what happens, these weren't two 84-year-old females. Actually, they were, one was 72 and one was 84. But the common thing that happens is there's or the demographics. We can talk about demographics and who gets these fractures. So the most common people that get these fractures are elderly patients, right? And the reason for that, these are fractures that happen in what we call osteoporotic, or patients with worse bone density. So me or you probably wouldn't get this fracture just from falling or slipping, or a low energy injury would require something like a car accident or something to that effect. And so what typically happens is patient will fall at home, usually. Maybe they use a walker, maybe they use a cane, maybe they should use a walker and they don't for a number of reasons. Patients end up just having some sort of not what would be an innocuous event for me or you, and they fall. And then the typical presentation, typically what happens, they get brought to the emergency department by some sort of emergency medical service. And the reason for that is inability to ambulate. So that's the most common pain, right? So it hurts like hell, and they can't walk. And so for that reason, they get brought in, and I get called. So then they get, radiographs, and to get radiographs of the pelvis and the femur and anything else that the patient says hurts at that point, or, whatever the emergency department decides they're going to x-ray, they'll get it, or CT scan. And I will get a call and say, hey, we think we have a patient with a femoral neck fracture. And I'll say, all right. And I'll review the imaging. Probably the most important thing that you learn as a resident, sort of the glaring and obvious thing to me is the femoral neck, and to everyone is the femoral neck fracture. But you have to sort of be very discerning and make sure you don't miss the non-displaced something else somewhere else. And so we review our imaging, but then of course x-rays are one thing, like Dr. Kott said, but the patient is another. So you have to go examine your patient and try and figure out exactly what happened, any other concomitant injuries that they may have, what their status is, not just a fracture wise or not just pain wise, but also what their living status is. So are they someone who walks with a walker or a cane? Do they have many medical comorbidities that'll make our process or pathway to surgery more or less tumultuous? Do they have do they take blood thinners? Is this a true fracture from falling, or is this something that's like pathologic perhaps? So do they have an underlying cancer that, you know, we need to be keeping in the back of our mind? So these are all things that I think about, and we all think about as residents every time we see patients with this injury. It helps to, and asking those questions, one, helps us to understand how we're going to get to surgery, but also helps us to give patients and families who are often there with these patients sort of a picture of how things may progress, or what the next steps will look like after the hospital, and how they'll progress in the next few months to few years. So complex question.
I think what's important to take away from that, though, is that we see these basically every day, like with them, and we do try to get to them as soon as possible. And the reason that we expedite their care so much, and we even have recently created this like hip fracture protocol system where the EP tries to call us immediately, and we try to do the same day. Is because the mortality is not insignificant with these, even though we see them so often. And they're elderly, and you know, we like to tell people that like, oh, we're just gonna fix your hip and you'll be fine, but like the mortality due to a lot of other factors is pretty high. It's like 50%, and most people will also lose a functional level. So if your grandma walks with a cane before she falls and has her hip surgery, she may need a walker afterwards. Like good horse for them need a walker. If you already use a walker, like you'd be lucky if you can use that walker. Then some people become very dependent on assistive devices. So it's just something to think about when you see these like cases, and it's very humbling to think that like, you know, we do 2 or 3 of these every day, and it's like one of those people is gonna make it, like that's just like statistics. So we take these very seriously, and there's a lot of like, literature out there and research being done to try to figure out how we can improve these outcomes and decrease mortality and morbidity. But it's just something that is still a work in progress.
Yeah, and you know, sort of as I've sort of progressed from 1, 2, 3, I've sort of taken that step back, and really you spend a lot of time, I'm spending probably more time than I should seeing these consults and talking to patients and families, and really counseling them on sort of, you know, that things are different now. I think of hip fractures now sort of a sentinel event in our patients' lives. So it, like Anna said, you know, a lot has happened to you to get, you know, yeah, a lot has happened to get you here, and a lot will happen, and you know, you'll be seeing physicians and people like me a lot for the next few for the foreseeable future.
And I think that's the best point. I mean, you know, your technical work here is excellent, and that probably took less than an hour.
It's easy for me. I tell them that, yeah.
But you know, who's ever taking care of this patient, this is 6-month minimum, you know, relationship, and probably even longer. And you know, what I'll tell people is they'll usually lose 1 functional grade in the best circumstances. And a functional grade, if they walk independently, they'll probably not be able to walk without a cane. If they were cane, they'll be in a walker, they'll probably be wheelchair. And that, you know, we shoot for that, but this is a life-changing event that Joe was showing.
Yeah. And it's, you know, on the flip side, so you're like, oh God, you do the surgery and people like to tear it. Well, without this sort of procedure is probably the other thing. You know, our patients say, well, can't it just heal? Can't it do well? So can't heal on its own because tenuous. It's tenuous plus fly, right? It won't do well. Beyond that, the healing of this fracture, if by some miracle it did, would take, you know, a long time, right? How long do bones take to heal? 6, 8, 10, 12 weeks. There'd be a lot of downtime for patients, and in this patient population, you know, they just don't do, even in you know, me or you, we just wouldn't do very well kind of sitting around for 2 months in bed in agony, waiting for our fracture to heal. There are a lot of complications that are associated. So sort of, you know, a rock and a hard place in some cases when we see our patients. So,
and the goal of all these hip fractures in our treatment is to make sure that they can try to ambulate. Like we want them to walk on them. A lot of times we're fixing things to make them non-weight bearing. We don't want them to destroy our fixation or have things move. But we want to get these people on their feet like post-op phase 1, if not 0, because we want to get like them moving. Because all of these complications usually come from them being bedbound.
Skin and soft tissue, pulmonary, and the like.
Operative management change if the person came with like a delayed presentation. So for example, like I know I've heard of cases where people don't go and get sent out for like a couple of weeks and they just kind of ignore it, whether it's for like insurance reasons or they don't have access to care. So would you still go through with like just putting screws in, or would you consider doing something like just a total joint replacement at that point?
Yeah. So excellent, excellent question. I hope we all heard that over Zoom, but asking how does the management change if the acuity has changed, if it's not, didn't fall a few hours ago, fell a few weeks or months ago. So typically fractures that in this region, if they're ignored and you get past that painful region, they're not non-displaced usually in a few weeks. They've completely displaced, and so that does change your management. We'll talk about that in our next fracture actually. So 2 hips, okay, 84-year-old, ground level fall, left femoral neck fracture, right? So this is, I think this just kind of highlights, right, when we get the call and we get femoral neck fracture, or someone says, we don't have x-rays, but we think they have a femoral neck fracture. They have it's this sort of 5-minute exam, right? Very low cost exam, really sort of changes our whole management. The way that we treat this patient, the way we think about it is going to be completely different based on understanding the radiograph. So you may hear us get upset, testy sometimes when they're like, oh, we don't have any x-rays, but the ankle's broken. Well, we need to see it. So it helps us. So that's the reason why, right? Because it's completely different, right? Same title, same caption, completely different. So we identified the fracture here before, right? So that's what's going on. And so if you look at this, those lines don't really match up, right? So what's happened in this case is not that there's an extra piece of bone, but the bones are now completely free. So that helps to highlight the displacement factor there. And so they're completely separate, completely displaced. And so this won't heal, right? You can't just put this back on top and, right, the blood supply is completely shredded, right? Because it was tenuous at best at first, and it's intracapsular, so we can't heal. So we do a replacement in this case, right? So either repair, replace. So we can't repair, so we replace and use what's called a hemiarthroplasty. And so some of you may have heard of a total hip arthroplasty, where you replace the acetabulum, which is highlighted a few slides ago, as well as the proximal femur. In this case, we just replace the proximal femur, and we allow this patient also to weight bear the same day or the next. This case is a little bit more daunting in terms of just the surgical approach for our patients. So there's a more soft tissue stripping and soft tissue dissection that has to happen. And so it is a little bit more taxing on our patients, but pretty uniform results relatively.
So Joe, unlike honest case where I saw screws that help the blade on, what's holding that piece of metal in the bone?
Prayer. No, so in this case, we're relying on what's called interference fit. So what happens, or how you get this implant into the femurs, right? We've taken out all the fractured, the diseased area of bone, and then we use what's called a broach, which is a metal device that clears away some of the bone in the intramedullary canal that's shaped just like this implant, and match the size. And so you'll hear people saying, we'll broach up to X size, and that'll tell you in your head what implant you'll need, what size implant you'll need that'll fit the area that's been broached. And so and so then you'll implant this with just a hammer. Not very hard, though, you'll fracture it. And so in this case, there's no cement, but in other cases, especially in the data is now kind of leaning that way, that cemented hemiarthroplasty or cemented hip replacements are better in the fracture setting for our patients in terms of outcomes and pain and so forth. So sometimes, right, we won't broach to the same exact size. We'll broach, and then we'll put a stem that's smaller, but we'll have cement around it, and that'll sort of glue it into the bone, so to speak.
Jomar, did you say that this was from your intern year?
This one was 2021. Yeah.
The reason I ask is because if this fracture shows up on my queue when I start practicing, this is getting cement, 100%. This is an anthology, it looks like, right?
Yep.
So the reason I ask all those questions is for those of you, one of the things that's cool about orthopedics is there's constantly intellectual stimulation in the sense that there's always research that's coming out, and you're always modifying or improving the way you practice and the way you treat patients, because you want to treat them, the right way. So as we discover things, you don't do the same thing for 30 years, is my point. And I'll bet you Dr. Cott will probably nod when I say this. The things that he did in fellowship, or the things that he did in residency, he's doing a lot of things, some things the same, but he's doing a good amount of things that he's followed the literature, and he's modified and stayed up with the cutting edge of how to do surgery. So, it's not boring, and it's not like you learn things one way and you do that for the rest of your career. You change. So when I was a senior resident or a chief resident with Jomar, I might have done this. I might have done a case just like this, but within the last couple of years, we have literature that's saying to do things maybe a little bit differently, which is fine. But there's always new things that are happening, which is kind of cool about the field.
That's a really good point. So in this case, we did what's called a press fit, right?
Yep.
You found the right size and you put the right size implant in there. So let's say you were off and you put an implant that was either too big or too small. What could potentially happen, and what would you tell the patient before you did the surgery? That could potentially happen if there was a incorrect size chosen, let's say.
Sure.
Start with too small.
Yeah.
Tell us about what would happen if it was too big.
So too small, the risk, or the thing that you're most scared of is what's called subsidence, right? So you can imagine if there are two cylinders and they don't fit exactly, and it's sort of the one on the inside doesn't sort of press fit or sort of create rely on the hoop stress. The hoop stress against the bone and press against the circumference of the canal. Over time, as you walk on it, it'll just kind of slide down, right? And we'll call it subside. That for patients, so patients don't say, "Oh, my stem is subsiding," right? They say it hurts. They say it hurts when I try to start walking, start up pain. Usually, they get femoral or thigh pain, and you wait long enough, there'll be a catastrophic failure. It'll dislocate. It'll spin in the canal. But that's how they'll start. Man, it never stopped hurting in my thigh. And then as far as too big, that usually probably doesn't make it out of the OR. If you go too big, it ends up, so you can imagine if, right, I don't know if you guys ever seen that Wile E. Coyote cartoon where the train is too big for the tunnel, and it just cracks, right? And so that can happen here. If you're too aggressive with your broaching, or if you're too aggressive with the implant size, it'll fracture, or the hoop stresses will be too great and it'll fracture, and then you have to do some things intraoperatively to correct that. So usually what happens is we'll remove the implant. This is after your attending has cursed you out, and then you'll and then you'll wrap something depending on the fracture, but usually it's what's called a calcar fracture, which is sort of a three-dimensional area in the bone that's very, very hard. You'll wrap a wire around, a cerclage wire around, so it sort of recreates that hoop stress, so it gives the bone back that hoop stress, and then you'll be able to broach again, and then you'll place a new implant that fits that new area that you've created that you can press fit. And this time you'll either be very careful doing it, or your attending will be doing it.
And then if you can't get it right, or you're not sure, as Dr. Mennona said, what's another option you have to kind of help fill in the gaps,
Yeah.
to transition from that stiff implant to the weak bone?
You can cement.
Right. I can just talk them through that and what we're trying to accomplish.
Yeah, so with cement, some of the things that change is that you're no longer relying on that press fit, right? So you're relying on a bone cement implant interface, and so you mix the cement intraoperatively. You place it into the canal. Usually there's some sort of what we call a restrictor, something that will stop the cement from just continuing to go down the canal, and then you'll place your implant in, and what one of the advantages that cement has that doing a press fit doesn't is that you can change the angle of the femoral head or the implant as you place it intraoperatively. Whereas if you don't broach it perfectly at the right angle, you sort of bought it, and so you'll place all your cement in, and then you'll squeeze the implant in on top of it. You'll really try to get pressurizing of the cement, and then you hold it until it hardens, and then from there, everything is roughly the same. The implant, of course, is smaller than if you had, you know, just broached up with a the same size implant. So,
And then last thing is talk about, you know, the consistency of bone marrow and what could potentially happen catastrophically if you're putting cement in someone's bone.
sure. So I guess you may be talking about pressurizing the femur. So one of the risks or things that you run the risk of is that as you squeeze the cement and squeeze the implant into the canal, it'll force bone marrow out of the canal. Where does it go, right? Can't just, there's nowhere else for it to go. So it can be forced into the some of the fat in there can be forced into the circulation, and you can get emboli from the fat flowing around, goes into your, same way you get a thrombotic emboli. You can get a fatty embolus as well.
And then what will happen?
And you want like symptoms or sure. So sort of in the same way.
In generality, what happens if that gets into your bloodstream?
Yeah, so it gets into your bloodstream, and then ultimately, right, all the blood ends up going to the lungs at some point, into the heart, right? It goes in the lungs, gets oxygen, goes to the heart. So what happens is the fat can't pass through the small venules, just like the thrombus can't pass through the smallest venules in the lungs, and it clogs them, and essentially you can't oxygenate new blood, right? That area gets cut off, and so they're like pulmonary requirement mismatches and so forth. But the short story is that these patients don't do well because they start getting pulmonary compromise and respiratory decline. And so what do you do for that, right? So there's no there's no anticoagulation, right, for these patients. It's treatment with oxygen therapy, just kind of high oxygen. And right.
And you're going to speak to your anesthesiologist colleague and let him know what you're doing so he can appropriately, you know, prepare the patient, you know, for that potential, you know, explode that comes in.
Yeah.
But the point being is that what we do in the hip has ramifications throughout the entire body. You know, the patient, and this patient had a great surgery, you come in 2 days later for morning rounds and you found out the patient died. I mean, that does happen. What mostly happened, you know, a reason for someone dying 2 days after a hip procedure. What would be a cause of that?
Sure. Some usually maybe it's 2 days kind of early, but yeah, wind, water. So dying, you can die from like a embolus, right? You can have a thrombotic embolus.
Or myocardial infarction, you know, something else happened. These are sick people that we're doing major surgery on that has, you know, a high mortality. So just to show the gravitas of what we're doing on a day-to-day basis.
Not just bone broke fix.
Going back to why was he saying that we probably submit this now? What's the benefit of cementing somebody like this?
Sure. So one, intraoperatively lowers your chance of complications, so lowers your chance of having intraoperative fractures. Two, these patients, I think, what is it? There's a pain benefit for our patients, and I think there's outcomes in terms of like mobility benefits and time out of the hospital as well. So there are papers that show it.
So I think the point that he's trying to say is that, like, when you look at an X-ray, sometimes you can sort of you kind of have a feel for how the quality of the bone. It's like, honestly, I can't really see well on this image, but sometimes you look at these X-rays and the cortices, which are like the bright white lines on the sides, are really, really, really thin. There's a whole classification that goes along with that to help you make a decision on whether or not you should think about cementing somebody or doing a press fit. But if the where Joe Mar's pointing is super, super thin, like that's the strong part of the bone. If that's super like a little white line, you're like, this is gonna be super weak. Like I shouldn't be broaching. That's like malleting, and that means it can shatter when you're doing that. And you're trying to put like your implant in. So you're like, maybe I should cement it, which means I don't have to like do as much broaching. Or I don't have to be malleting the implant in. I can just, you know, make a little hole and then put cement in, and then that's it. You're less likely to have causal intraoperative fracture, which is what Jomar was saying. And so especially in like the older patient population, a lot of the literature saying like if you're really old, you have osteoporosis or osteopenia, like you should consider cementing these patients because you're less likely to cause a fracture.
Just remind me, on my presentation, I have an X-ray of what you do if that breaks.
Oh, nice.
So
yeah, come on up. Yeah. So yeah, this one, it was just an inner troch. So this fracture, can anyone identify it? I'll show you. It's right here. So right. So first thing, right, is it a left or right? It's a right. Inner trochanteric, right? So it's outside of the femoral neck region, right? It's now, and you may be like, where is the fracture? I can't see it. What are these squiggly white lines here? It's right here, right? So out of the femoral neck, right? So we're out of the tenuous blood supply, we're out of the capsule, we're gonna heal right here. And so this is what we do. We don't replace, we use a screw and nail, and we can get into it, but let's have Jason start chat. Maybe we can save this one for another time. Hold on. Thanks.
Oh, yeah.
Mine's still plugged in. Oh, no, it's not. Is this mine?
Yes. What's going on? Are you gonna show stuff in Pablo? No. Ankles. Oops.
All right. Hey guys, I'm Jason. I'm one of the PGY2s. Just a show of hands, how many of you guys are M1s, M2s, 3s, 4s? You guys are all M1s? Mostly 1s, 2s, 1, 2s. Hey. Okay, all right. So I was actually a medical student here too. So I was sitting where you guys were sitting not too long ago. Thanks back memories. All right, so as Dr. Mennona was saying earlier, orthopedic surgeons wear many hats. One of the first hats you wear is you're also a radiologist. So your intern year, you learn how to read x-rays. And the best way to do that is to look at a bunch of normal x-rays. So we'll start off by just looking at normal views of an ankle. So anyone want to tell me what views these are? The one all the way on the left is straight on. We call that an AP. Yep. The one in the middle is a little bit tilted, oblique. And the one on the right is on the side, lateral, right? So in a lot of other body parts, the oblique view is actually not the most useful. Sometimes it kind of skews what you're looking at. Like Anna was saying, the orthogonal views are super helpful because it gives you the 90-90 view, you can get a good idea. But the oblique view, sometimes it kind of misconstrue the fracture pattern. In the ankle, the oblique view is actually arguably the most important. In fact, it's so important they gave it its own name. It's called a mortise view, M-O-R-T-I-S-E. So the reason for that is if you look in the middle picture, you can see that black line that goes around that. So that bone on the bottom, you see it's kind of look like a trapezoid. That's called your talus. So if everyone just does this with their foot, right, that's your talus. That's shaped like a dome articulating with your ankle joint, which kind of covers it like a helmet. So with the mortise view, you can see the space all around the talus, and that's really important. Yeah, and you know, there's like literature that says like if you have 1 millimeter of displacement of that talus from that tibia joint, so that's your tibia is a big one, the fibula is a small one, you get like 42% change in tibial contact, which causes like early arthritis. So it's pretty bad. So it's really important to get a good reduction of that talus under that joint. I know a lot of you guys haven't really had anatomy yet, so we'll kind of, you know, we won't go too detailed into this, but your bones, you have your medial malleolus, the lateral malleolus, and the posterior malleolus, like you saw in the prior picture, right? That posterior malleolus is like an outpouch of the posterior tibia. Syndesmosis is kind of like your ligamentous constraints. So you don't have to don't worry about memorizing all this now, but these ligaments are really important. So so this is your deltoid ligament on the medial side. That's really important. It's like your big ligament that prevents your talus from translating medially. And on the lateral side, you have your syndesmosis, which is a series of, you know, this ligament here, this ligament here, this ligament here, this ligament here. This is actually the strongest one, so that's really important. And this, you know, keep in mind where this is, because a lot of what we do with ankle fractures is dependent on where the fracture is in relation to that ligamentous structure. These are just some parameters you can look at for looking at displacement. So like I said, that mortise view is super important. The medial clear space is what we use a lot. If it's bigger than, usually use 5 millimeters, and usually that means that the talus is unstable. You can also look at the tibiofibular space, which is up here. It's usually 1 centimeter above the joint. You look at it, if it's less than 6 millimeters, then that's normal. If it's greater than 6 millimeters, you have a problem. So as you get, more closer to your fourth year, you're expected to know a little bit more about classifications. A lot of classifications in orthopedics are more academic and don't really guide management. This one is really useful for management. The Weber classification, this is all based on syndesmosis, which we were just looking at. So the A fracture is infrasyndesmotic. So you can see that the syndesmosis would be about here. So if it's below the syndesmosis, we usually treat that non-operatively because it's stable, right? You can see the talus isn't going to shift. And you can usually treat that weight bearing as tolerated, send them out in like an air cast, and they can walk home on that. Your Weber B is at the level of syndesmosis. And that gets a little bit trickier because that one can be unstable or it can be stable too. And there's some ways to discern that. And then your Weber C is suprasyndesmotic. So it's way above the syndesmosis. And that has the highest likelihood of having a syndesmotic injury because your interosseous ligament that goes between your tibia and your fibula is usually injured with that. And this is what it looks like on X-ray. So A, B, C. And there's another classification. Again, don't go crazy with this, but Lange-Hansen classification basically just shows that the mechanism by which you injure your ankle can kind of predict the fracture pattern. And that can be important when you're trying to fix it with surgery because certain constructs won't work for certain fracture patterns. So you can imagine if you supinate your foot and you adduct like this, the force will cause like a vertical fracture on the medial side. So that would be different than if you had a transverse fracture. You'd have to treat that a little differently. So, we'll get into this. This is a 44-year-old patient who had a fall, and does anyone want to try and describe what they see here?
So Jason, tell me about this patient. You just got called to see him. It might be in the emergency room.
Mm-hmm.
Tell me what's going through this person's mind. What does the ankle look like from the outside? Are they uncomfortable? Do they walk in? What's going on?
Yeah, so oftentimes these patients are very uncomfortable. They're writhing in pain. Their ankle is grossly deformed. You can see, like, you walk into the room and someone's like, oh, there's something wrong with your ankle there. So typically, what you do is make sure they have adequate pain control so that they can talk to you. Usually they'll tell you, oh, I had some sort of injury playing soccer, I fell downstairs, something like that. And then, the first thing you want to do is get those fracture fragments back into alignment. So you have to reduce it. That's your closed reduction, like Anna was talking about. And the way you do that is you give them first an intra-articular lidocaine block. So you give them a lidocaine block right into the ankle joint, and that reduces their pain enough so that you can manipulate it a little bit. And that way you can get the fragments back into the right spot.
You want to try to get the fragments in better position.
So, right. So you could say, oh, this is going to go for surgery. You don't have to reduce that. You can just let it sit. But, let's say, for example, that this patient elopes from the hospital and now they're in a splint that's malreduced and it's never going to heal or if it does heal, it's going to lead to a malunion or it's going to heal in the wrong position. So now your talus is not in the right alignment. Like we were talking about earlier, you're probably going to get really early on like post-traumatic arthritis. And you're looking at like a fusion down the road when you're like way earlier than you want that. Yeah. Yep, definitely.
Pain control, soft tissue, pain control. So that's how patients, IV injections help you feel a little better. Lidocaine helps you feel a little better, and then getting the bones in the right orientation and getting immobilized feels the best.
And you're probably going to show us the surgery, but let's say this wasn't splinted for a day or two. What would the ankle look like then?
So you probably have some, and then you have to worry about like wound complications of soft tissues, right? So orthopedics isn't just about bones, it's about soft tissues too. So like something on the medial side, you can see that if you leave that for too long, you could get wound breakdown in the medial side that can start poking through the skin. That could become an open fracture. You can get an ulcer, you can get infected, especially if they're diabetic. Fracture blisters. So if you see like boils or something, that's a sign that's telling you the skin and the soft tissue is like under stress. And so oftentimes if you see that, we may, that alone might make us change our management. You might have to do an X fix on that and let the soft tissues heal. So it's important to do a good exam and to keep the soft tissues in mind. Also, also sometimes if you were trying to reduce it, like the soft tissues can block a reduction. So let's say you're trying to reduce something from medial to lateral, like you have tendons that go there. So if you can't get it reduced, well, you can't just give up. You have to understand why, and you understand that probably needs to go for surgery for some reason or other.
And the ankle is really sensitive to operate on because both of the bones where we put our hardware are like, if you feel your own ankle, like you can feel your bone. So you can feel, like if you have hardware there, like you're gonna feel it. And if you have soft tissue compromise, even like this tiniest little wound breakdown can be huge. Like you can just see the hardware there. So we don't like to operate on the area unless the skin is like perfect. Otherwise we're just like going to be causing more problems rather than solution.
Then you're getting infected hardware. You got to take it out. You got to be on antibiotics, and now they can't walk for months. So it's, it's better to do it right the first time and make sure that everything's under control. And then the soft tissues also help the bones heal better too. If you have like good healthy tissue around the bone, it's going to heal better.
And Jason was talking about the Lange-Hansen classification, which is good for, I think this just describing like patterns. And it gives you an idea of what the mechanism of injury is. But I think honestly, the easier way to understand it is just calling it by how many malleoli are affected. So you usually describe it in 3 malleoli, or there's the lateral malleolus, which is the fibula essentially, the medial malleolus, which is the tibia, which is projecting there, and then on the lateral you can see the posterior malleolus, just sort of that like jutting out area of the bone. So you can just say it's a bimalleolar like fracture, which just means that two of them are fractured, which is super common. It's usually just the tibia and the medial, or what am I saying? The fibula and the medial malleolus, although you can sometimes get variations of that. And then if all 3 are broken, you say trimalleolar fracture. And that just gives us an idea, like when we're communicating with each other, like, what sides we're going to be needed to work on. If it's a trimal, if the posterior mal is really big, then how we're going to be positioning that patient that potentially when we're doing the procedure. Because even that, like oftentimes the posterior malleolus is so small that we don't even surgically address it. But sometimes it's big enough and that we have to, potentially flip the patient over and do the surgery while the patient's what's called prone, which is face down. So we can actually like look at that piece and put it back where it belongs.
That was a perfect segue into the next part. So, given what Dr. Green just described, how would you describe these malleoli? How many malleoli are fractured, and what would you call that? Yeah. It's a bimalleolar fracture. The medial malleolus and the lateral malleolus are both fractured, so you can see that the talus is unstable. So would you operate or let that heal on its own? Right, so those bones aren't going to stay there. So the first thing you do is, like we were discussing, you do a closed reduction, put a splint on it. And when you're doing your reduction, you want to make sure that mortise view, you have good space. You close down that space, right? So on this view, you can see there's a big space here, right? Medially, that medial clear space we were talking about. So you got to make sure that's closed down. And then, and you don't want that foot to be straight. We don't like straight splints, is what we say. So you want to correct the deformity. So you want that closed down. And then we took him for an ORAF.
So very simplistically, fractures around the joints, you want to get those perfect or as close to perfect as you can. And in contrast, the first fracture Anna presented, that humeral shaft fracture, we have a little more leeway when it's in the middle of the bone. And that, may also determine what kind of implants we use. But, Jason will tell you, this is a rigid implant, so it's nice and strong, and it's going to hold that joint, perfectly aligned. And what would happen if it wasn't aligned correctly and the joint was off? What is likely to happen to that patient down the line?
Oh, they'll get bad arthritis and probably need fusion, and probably have significant pain for a while. Won't be able to walk, do sports the way they used to.
Exactly.
Yeah.
So this is different than a hip fracture that dies 2 days later. This is the one that if you don't do a good job, it's going to come back and, plague you, throughout your career, because you're going to watch progressive arthritis and further increased disability as they go along.
Mm-hmm.
So how did you fix this? What did you use there?
So, you can look at the medial side and the lateral side. So on the lateral side, you use most people use what's called a 1/3 tubular plate, which is a very simple plate. You kind of, you do your approach. It's a relatively simple approach since the bone is right there. You make sure you don't hit the superficial peroneal nerve, which you learn about. And then once you're at the bone, you kind of debride it, and then you put the plate on with the fracture in the middle. There's one screw here, right there, that doesn't go through the plate. That's called a lag screw. So if you look on this part, like the fracture line is kind of like this, and the screw is kind of going across the screw. The screw is going across the fracture site. And the point of that is to try and bring those pieces together, like Jomar was talking about. Like the threads will bite and the head will stay, so compress the fracture site. But that one screw alone isn't going to be strong enough to hold that when you're walking on it. So you typically support that with a plate on the side. And with this plate, you have, 3 screws proximally and 2 screws distally. What's different about the screws proximally from the ones distally? You can use non-orthopedic, non-medical, normal human words. Okay. What about the shape? Like, what about, look at right? Yeah. Yeah. So like on the bottom ones, the threads are much bigger and more spaced out. Call it the pitch of the screw versus these ones up here, which are denser. So cortical bone, or like the bone on the outside, is much denser bone, whereas bone like in the metaphysis is like spongier and softer. So they actually designed specific screws that bite into certain types of bone better. So to get that distal bone fixation, they actually make these screws with bigger pitches. And then the ones that are proximal also go bicortical. So you're crossing both cortices. That's giving you stronger, more rigid fixation. The one distally, you could go bicortical, but I think a lot of the surgeons here like to go unicortical to avoid going into the joint line there. Because if you can imagine, if you have a screw that's going into that joint line, that's going to be really painful. And on the medial side, you just do, why can't you just do one screw there? Well, it doesn't, common sense will tell you if you have a free floating bone and you just put one screw through it, it'll rotate, right? So you put 2 screws to prevent rotation. And yeah, and that's stable.
The lag screw that you use laterally, the lag screw that you use.
You mean like partially threaded? So yeah, so the ones medially, like Jomar was talking about in his talk, like there's threads in the disc, like this part. Can you see my? Yeah, there's threads here and no threads here. So the point of that is that this bites the bone and this glides.
So the technical name for that is something called lagging by design. These are partially threaded screws. To keep things simple for the medical students, what's kind of cool about looking at this X-ray is the X-ray tells a story of how the surgery was done with what certain technique. And by looking at the instruments, you can tell how the fracture was reduced and also fixed. So just by looking at that screw, the approach that was taken, the trajectory. There's a lot of investigative work, and it's kind of cool. The other thing is there's also like trademarks. I can almost guarantee that's Sahabian to this case, right?
Yep.
The reason I know that is because Sahabian uses a 2-0 lag screw on his fibulas, and that's what that little screw there in the middle is. And Sahabian tends to put his plate laterally, which is, you could see it on the lateral there. And he's a fantastic surgeon. So, if you develop a style, then you can look at an X-ray and know who did that case without anything else. And I'll bet you that's a 35 and a 40 screw on the medial side. But yeah, it's kind of cool.
Mm-hmm.
So Jason, what's on the outside of the patient's leg? And this guy, let's say, is 40 years old, he's a mechanic, and he likes to play recreational soccer. What are you going to tell him this next 6 months are going to be like?
So for the next, probably 6 to 8 weeks, you're really not going to be doing any sort of sports. So you normally, like, you have them be non-weight bearing for a minimum, I would say 4 weeks. And then you see him in the office, you get new x-rays, you see how the fracture is doing. If it's healing appropriately, you can try to switch him to a cam walking boot, which is a lot more comfortable than a splint. It's like, oh yeah, it's like a big like Velcro boot that goes up to here. It's like a snowboarding boot. If anyone's, yeah. And you can take it off to like, go to bed and shower, and you can put it back on. So it's a lot more comfortable.
And then return to work, return to play, rough estimate.
So I would say probably, 8 to 10 weeks is like when you can start kind of resuming normal activity. If you're like a diabetic, usually we made like 10 to 12 weeks.
And then return back to sport probably, a couple months later. So
yeah, like 3 months later.
A day and a half in the hospital, and again, 6 months before, you're back to function, at a certain level. So, another major, investment of time and energy, and treatment that probably is going to change the person's life, as opposed to at the end, nothing done and, got wrapped up in an expanded.
Exactly.
So, excellent job.
Thanks. So next is another patient who had a not quite the same type of fracture. What's different about this one? And why is the name what it's named? Right. So how many malleoli are fractured here? Yeah, it's only one. It's only the lateral malleolus, but there's a big ligament here that we were talking about earlier called the deltoid ligament, which you'll learn about later. That's usually ruptured here, but the medial malleolus, the bony medial malleolus is intact. So we call that a bimalleolar equivalent. So it's essentially the same. You treat it the same.
What would happen if you just put the patient in the cast?
Again, this would probably be unstable because that deltoid ligament is going to prevent it from shifting translationally. So if you don't do something about that, it's probably going to move around. Even if you reduce it well in a good cast, it's a likelihood of it staying there is not high. So I think most people would try to fix this, which was what we did here. This is a slightly different plate. It's like a locking plate. You can see there's like a smaller screws at the end to give you fixation there. And then there's one big screw going across. We call that a syndesmotic screw because it goes across syndesmosis. And usually you check that by intraoperatively. After you put the plate on, you fix the fractures, you stress the syndesmosis, you see if it widens and gaps that medial clear space. If it widens, then you have to fix the syndesmosis. So this is a Weber B lateral malleolus fracture. Looks okay, right? Medial malleolus looks okay. Deltoid ligament looks okay. But then there's this. So in the ER, so in the ER, you get this fracture and you think everything's fine. It's a Weber B. It's not going to need surgery. Well, you have to stress it. So it's called a stress view. You can do that with either gravity stress or manual stress. And you just externally rotate the ankle and you can see that medial clear space opens. So that's we call that a stress positive Weber B. And that, again, usually needs surgery. Oh, I think that patient actually refused surgery, but they should have gotten surgery. What's that? Oh, I don't have a nail. Yeah. As a Weber C. This is there's a little posterior mal here. CAT scan. So like Anna was saying before, like a lot of the posterior malleoli we leave. We don't have to do anything for unless it takes up like 25% of the surface area. So this one, you just treat it like a regular bimal.
Just explain what that diagnostic modality is.
Oh, that's right. Yeah. So that's a CAT scan. So X-rays alone give you like a static view of the picture in time, but the CAT scan will let you, and usually there's other views. I'm sorry, I only included the one view here, but usually this is an axial view. So it's like you're taking a cross section, you're chopping your leg straight down the middle. And then there's also a sagittal view, which is the side, and then the coronal, which is the straight on front. So usually that's what a CAT scan will show you. And you can see when I hit play here, that'll give you kind of like a 3D rendering of, the entire thing. You have to know your anatomy to understand what you're looking at, because you have to kind of like superimpose it in your head as you're looking at it. But this is the very end of the tibia and then the end of the fibula. So you can see that fracture in the cross section. Does that make sense? Yeah. And then this is a bad trimal that, you know, this CAT scan, actually, I have more stuff here, but this one you can see has a lot bigger posterior malleolus piece. Right, you can see that it looks like more than the last one. On this view, you can see the the fracture pattern there, right? You can see that joint line is incongruent. The talus isn't congruent with the joint there. And there's a 3D. That's a pretty big piece. So we actually ended up fixing that one. So this one's kind of cool. It's a lot of different stuff going on here. So we actually had to do a posterior posterolateral approach here and put a plate on the back.
Did Lou do that one?
He did, yeah.
Yeah.
You can tell from the tension band.
Yep.
Yeah. Yeah, so the what he's talking about is on the medial malleolus here, you have it's called a tension band construct. It's not like the two screws we saw earlier. It's like two pins that shoot across and then like a post screw. And then you take a wire and you like tie it around. And it's like just a different way to fix it. So yeah, I mean, ankle fractures like seems simple, but there's a lot of different things that can go into it. A lot of different patients you have to take into consideration. Some patients like just refuse surgery, and you have to explain to them like why it's important that you think they should get surgery and try and help them make what you think is the right decision. You have to know who to follow. You have to know who you can splint and cast and train on operatively versus who's not going to do well. So yeah,
That's great. Steve, you want to show one or two quick ones, and then we'll.
Yeah, sounds good. Just let me share the screen and then we'll blow through some stuff.
That's great. Then we're just going to ask the residents a couple personal questions, and then we'll wrap up.
I think another thing I was thinking about with ankles, particularly in the clinic, is that it's one of the other like very common injuries that we see. But there's so much variation in the type of ankle fracture that you get. There's some people, especially like the younger patients with simple patterns that may do great. They're always like almost always non-weight bearing, although there's some literature that says you can start earlier weight bearing and some fracture patterns with good stability, but I won't get into that. But I feel like it is important to counsel people that they're not going to be feeling normal for a long time, and they could be swollen for a long time after ankle fracture. Like even like months after, like they're out of their boot, they're in their shoe, and they're like, my ankle's still swollen, it's achy, and I'm like, that is normal. Like your ankle's gonna be swollen for like a year, like even sometimes longer. Like get used to it, and people can be very, very stiff after this surgery too. So it's not like I feel like it's like one of those really debilitating injuries to have, even if you're like young and healthy.
So I think those are all great points. So first off, great job to the residents that made their presentations. And as medical students, you're like, oh wow, like how do I get from where I am to being as knowledgeable as them? And it takes a lot of work, takes a lot of studying. What I want to do is I just want to tell you why orthopedics is really cool. So I'm just going to show you cool cases. I'm not going to get into the minutia. Some of these I did during my trauma fellowship last year. Some of them I did during an adult reconstruction, which is joint replacement fellowship. So this is more just cool stuff and what you can do as an orthopedic surgeon. So this is a 21-year-old male that actually was on the highway in Ohio and was firing a handgun at cars. He like stepped out into the road and was firing at cars. I think got like 7 or 8 shots off, and then the police got there and he got into like a gunfight with them, and he got hit with a high-powered assault rifle in the right hip. So he went down. He was placed under arrest and he was rushed to the hospital. And I'll show you his X-rays over here. So this is what happens when a high-powered hollow point bullet hits bone, blows it apart. And you can see all that dark or that very solid white stuff. That's the bullet fragments. And then you can see over here. Can you guys see my mouse? Yep. Yeah. So you can see this is the femoral head. This is the greater troch, and then this is the femoral shaft. And you don't really need a classification system to know that this is bad, right? The other thing that this guy had, because of the energy of the bullet, this tore through a lot of his neurovascular structures. And Jomar showed what if you can kind of remember those arteries that were over here, okay, those got messed up. So this guy actually had a very bad vascular injury. So now you have someone that comes in, and I was getting done with cases. This is around 4 o'clock in the afternoon. And if you do nothing, this patient's going to die. He's going to die because he has a femoral artery laceration, and that needs to be repaired. So vascular surgery has to do that. Now, the problem is, because of all this comminution, the bone not being where it's supposed to be, the artery can't be repaired in a safe way until the bone's repaired in a safe way, if that makes any sense. So you're actually doing life-saving surgery in this situation. So what I did here was, this is something called an antegrade femoral nail. This guy also had compartment syndrome. We don't really need to get into that, but I had to basically open up his leg from his knee all the way up to his hip, and I had to decompress all the muscles in his leg. And then we put a femoral nail in. So this nail is starting over here, and then it's going down into the femur. And you can see here that it lines up, and it actually, aside from this bone that's missing, it looks like a femur again. And then vascular surgery went in, and they did a femoral artery repair and bypass, which is kind of cool, but saved this guy's life. Whether or not he was doing the right thing beforehand, that's a different story. But you can see the incision was all the way over here. So we did something called a fasciotomy on him. So that's cool case number one. Second one, now that's life-saving trauma surgery where you rock and roll. You know, that's number one. Now on the other side, that I did that during my trauma fellowship. This is a patient. She's 83 years old. And this is how you make someone's life better, quality of life. She's 83 and she has bad arthritis. Now this is a pelvis x-ray. Okay. This is a good hip. This is a bad hip. And you can kind of see that the black space in there, that's joint space, whether it's cartilage, synovial fluid, but that space right there, that space is smaller than over here. So this hip is arthritic and it's painful. So you would do something called a total hip replacement. So she talks to the surgeon. We go through the risks and benefits. Don't have to get into those, but we're going to do a total hip on her to make her better. We make a number of measurements. We look at her spine to see how stiff it is. You could see someone already did a knee replacement on her. Now, unfortunately, she falls a week before her surgery and she has this intratrochanteric hip fracture. So she goes back to the same surgeon and says, well, my hip hurts, but it hurts for a different reason, right? So now you shift gears and you fix that. This is something called a long intratrochanteric nail. A bunch of different companies make it. This is a gamma nail. So you fix the hip, but her hip is still arthritic. It didn't change. But this allows her to walk, and we talked about the mortality. And you get her back up and ambulating. Then she comes back and she's like, you know what, my hip still hurts. So now you shift gears again and you do a total hip replacement. So now this lady had 2 different problems, and as an orthopedic surgeon, you can treat both of them, which is actually really cool. And this is her 2 weeks post-op, and this is her walking around, 2 weeks after surgery. This is a lady that had a lot of hip pain, had a bad hip fracture, and then a hip replacement. And you can see that she's walking around and doing well. So you as a physician are a healer, and you can, make them do better. Now, sometimes things don't go well in the OR, and you can break the femur intraoperatively, like we were saying. So that was something that I did a couple weeks ago that Jomar talked about. This is a patient that has a chronic infection and has undergone multiple revision surgeries. We actually had to take out her entire bone because this was infected with a fungus called Candida albicans. And you can see that you guys wouldn't really know to look, but this bone is really horrible here. And basically her options are very limited. You might actually need to amputate her leg because she has a horrible infection, but we have a couple of tricks up our sleeve. This is called a total femur replacement with a complex acetabular reconstruction. So basically you put in a complete femur, and it goes down into the tibia. But you have someone that may lose their leg, and you can, this is like a life-changing surgery. She's doing pretty well. This is someone that had a proximal humerus fracture, kind of a fracture similar to what Anna was talking about, but it's above and below a plate, and they actually have a distal humerus fracture here. So in that situation, you can put plates on plates on plates. And, this patient also did very, very well. So, those are just a couple of things that are all within the armamentarium of an orthopedic surgeon. And obviously you have to start somewhere. You have to start you got to learn how to crawl before you can walk, and walk before you can run. But this stuff is very, very cool. Depending on what field you want to go into. It's very exciting. There's a lot of, a lot of different aspects to it. There's a lot of different ways that you can treat people. But I just wanted to leave you guys, if you're going to walk out of here, there's a lot of information that was thrown at you, but what I want you to walk out from my talk, at least, is some of this stuff is pretty cool. Any questions?
I have one. So with the lady that had an arthritic hip,
Yeah.
how come you didn't just do the total hip replacements after the fall? Why did she first get it?
Why didn't I do the total hip right here?
Yeah.
Yeah, I mean, because so basically, if I did a total hip with this fracture, you could do it, but this comes back to your anatomy. Her greater trochanter, this is like a subtrochanteric fracture. If I wanted to put a total hip replacement in her, this part of bone has to be functional, intact to have a well-functioning hip replacement, and it's not healed. So I would put a hip replacement in, like I would put this implant in right over here, right? But you can see over here that even though it's not perfect, it's healed. And the muscles that attach from here to here, your abductors, need to function in order for you to have a stable hip. So it's kind of an upper level question, but it would be doing the wrong treatment for the wrong fracture. If that makes any sense.
I see. Thank you.
Yep. Other questions?
So Steve, just to make it a little more personal.
Sure.
You spent 9 years here at Rutgers. You spent a year in Ohio. Now you're in the city and you're coming back to the area. What advice do you have for these starting students on their path? And, how do you feel about orthopedics now, 11 years after you came to medical school?
Sure. So number one, it's a calling, right? This isn't a 9-to-5 job. And I'm sure a lot of you have friends out there that went into business or went into, another field, and they have a much more routine schedule. This is not that. And I think the one thing that you need to know is that it does take time. It does take hard work. There are people you have to remember, there are people that are on the operating room table that are paralyzed and asleep, and they trust you to cut them, to make an incision, and then go into their body and make it better. And that's an incredible responsibility, but to have that responsibility and to have that ability, it takes a lot of training. It takes a lot of mental fortitude. So that's part of the journey. And it's been a long time for me. Like Dr. Cott was saying, I'm in 4 years of med school, 7 years of training, 5 of residency. So 11 years after college. And do I think it's, the first question is it worth it? Absolutely. I think we have the best job in the world. You really make a positive impact on people. And also, the people that you work with are going to be some of the hardest workers and some of the most intelligent people that you'll interact with too. And, on a personal level also, I had a family member that injured themselves about 3 weeks ago or 4 weeks ago, and they wound up going to Robert Wood, and they needed surgery. And I actually called or I texted Dr. Green, and she was on call. And what's kind of cool is I didn't really have to worry once I knew that Dr. Green was there, and the attending Dr. Pushan was like, I didn't need to worry about it, because the colleagues that you have, they're the best and the brightest in medicine, which is kind of cool. And then, but the last thing I'll say is that it's a roller coaster. You're going to have, and this goes, for med school and the specialty, you're going to have your good days. You're going to have your bad days. You're going to have your days where you're tired. You're going to have your days where you feel like you're on top of the world. And it's kind of, the up and down thing, just like any other part of medicine, but definitely worth it. And it's a great ride.
That's great. Thank you. I'll turn it over to Hannah. Tell us about the camaraderie of the residency of orthopedic surgeons in general, maybe what other subspecialties you were looking at, and what your plans are now going forward. And you're a PGY4, so you're a senior resident kind of.
So I will say, whenever this goes, any program that you go into, but your residency, especially people that you end up spending 5 years with, become your family. I see my co-residents more than I see my family. Definitely my parents, but probably more than I see my fiance too. And so you spend a lot of time with them. You're kind of in the trenches. It's very stressful sometimes. Sometimes you feel like you're having like sibling like battles with them because you're like, you know, you're all tired and everything's high pressure. But you really get to know them and you get to know their significant others. And so it's kind of an experience that I didn't really know what it was going to be like until I was here. But all of my closest friends are now my co-residents. And I hang out with especially my year specifically, we hang out a lot together outside of work. So I see them too much probably. But yeah, I mean, it's a great experience and it's nice to have people you can rely on personally and professionally. I already forgot all your other questions.
So where are you going from here?
Oh, so I'm a PGY4. I'm currently interviewing for upper extremities fellowships. So my goal obviously is to go into hand and upper extremity after my PGY5 year. And then we'll see where life takes me from there. But
Fantastic. Joe, where you come from, where you're going, kind of tips and tricks, what can you share?
Where I've
In
come
2
from.
minutes.
Sure, yeah, right, yeah. I guess, I started not from the States, like, or sort of maybe an unorthodox pathway. I grew up in Jamaica and then made my way up to New Jersey. I had to do that, don't worry about it. And then to Virginia and then back up to New Jersey. It's been kind of a ride since then. You know, I guess probably one of the things that has helped me a lot, or that I think about a lot, or I think that it's been very, very crucial for me. Is just sort of being in somewhere different for me. It's always been useful for me to kind of meet people where they are and recognize that, you know, just because people are different or do things differently doesn't mean that it's necessarily wrong or not thoughtful. So just sort of I really think towards when I pay attention to the people and how they interact. I think that is an important thing. Probably one of the things that I didn't realize that I would that would happen in, you know, going into med school and going to residencies, kind of just like the plethora of life situations that you'll encounter, from your patients to the people you work with to, you know, the people who mentor you. Just kind of really, I think about that a lot. I think that's helped me to grow. So outside, I know, away from, you know, the reading and the studying and all that stuff, I think that's important too. There are people behind all these X-rays, and there are people who have kind of got you to where you are. So I remember that. That's good.
And Jason, you were a medical student here too. Talk about the transition from being a medical student now to being a medical. What was it like?
Yeah, it was probably one of the biggest transitions of my life. I mean, becoming an intern, you're dealt an enormous amount of responsibility that you're just not used to having. All of a sudden, you're responsible for all these people that you've never met before. It's like when you're tired and you want to just lay down in the bed, and you have to get up and do the right thing. Like, it's like a new situation that I found myself struggling with for a while. I was like, oh my God, I'm so tired. I don't know if I can do all this. I don't know if I can handle all this. And then, you know, you have to, and you level up and you find a way, and you look at seniors and peers and people above you and ahead of you and say, they did it, I can do it too. So, you know, I think for me, junior year residency teaches you a lot about yourself. It teaches you where your limits are and how to get past them. Medical school is great for accruing knowledge, and then start residency and put everything together. Put everything that you got. See, it's hard, but it's rewarding.
I think that's a good point. And I mean, just for the students on the call, the students are here. I mean, these are 3 of the top residents at Robert Wood. I mean, they're top residents in the orthopedic program, which is usually one of the strongest. They were at the top of their class in medical school. You know, and not only are they great surgeons on their path to becoming great surgeons, but they're good doctors. They think about the patient, and they're really good people. So, you know, that's what, when you say, what are you looking for in the orthopedic residents? I mean, you know, these 3 individuals embody that in being a good person first, being a good doctor second, and then the third part just being, you know, very technically good and being a good surgeon. And they hit all the boxes. So they're all great writers, they've written papers, and they find a way to do it with smart. So I'm really glad that they were able to come. I mean, hopefully you guys have just a couple questions for them, maybe for like the next 5 or 10 minutes. And it can be something personal, it can be something technical, you know, while you have them here, you know, use it to maybe ask a question or two.
Dr. Cott, I'm gonna jump off.
Okay, thank you so much for being on. That was fantastic. Maybe we'll have you back in a couple months.
Hey, I'm looking forward to it. Good luck, everybody. It's gonna be okay. See you later.
Question about third year, fourth year residency later on. What's on your mind?
I guess what are ways you can get more involved in research?
You want to take that one or on it? Yeah.
I mean, I feel like there's always like tons of ideas floating around. Hold on, I'm trying to get my USB out here. Honestly, at this point, I feel like there's almost like, wait. I mean, I don't know. Like, we have this whole like interest group in an Excel document, and which helps keep things organized. But I do think like there's so many of you guys, and there's only so many of us and faculty. We're always happy to help. Right now, I mean, it's difficult to do research in residency, probably regardless of where you go, but certainly in a program where, like, you know, we have just a ton of cases that we're doing. If you're interested in doing it, you know, you can always think of an idea yourself, and we can help. We, as in the residents and as well as the faculty, can help, you know, form that idea into some sort of like research question. Because I think at this point we're probably saturated with like projects ongoing. There may be a few that are sort of like looking for more manpower, but obviously like there's tons of things that could be researched or ideas or that we can help with. But you know, just reaching out, being like, I have a question, like I am really interested in like, you know, total joints and infections, and you can email, you know, you can email the attendings and see like who the residents are who are interested in joints, which we don't film on right now. And then be like, you know, I have this question, like, are you interested in, you know, helping me? And you can, you know, figure it out. But I feel like the best way is to take up a question yourself, probably, and then just like, and it could be like so dumb, and that's fine because you're an M1 and 2 and 3 and 4, and we don't expect you to be experts in the field by any means. We're just having some sort of question or idea or topic, even, and then like coming up to a resident and being like, you know, I'm interested in, is there someone else who's interested in it with me? And then finding someone that can help you develop a refined research question, and then you can go from there. And we're always happy to help with that.
Yeah, and I think Anna makes some good points, and I think it's also being in the right place at the right time. You know, certain programs have, you know, thousands of things going on in a huge research department, which we don't have. But, you know, things come up, and you know what, I got an email from someone, and oh yeah, we're working on this, we could use somebody else. So you came to, you know, the pediatric clinic, and you say to the resident, hey, is anything going on with research or the attending? And let me know, and maybe follow up with an email a month later and say, oh, just following up, is something going on? Or, you know, you know, keep your name out there, and just, you know, most of the time it won't lead anywhere, but the time it does, you know, grab it and then see where it goes. Because sometimes you kind of get into the pipeline, and then one thing turns into the next. And I mean, Joe, you can speak to that a little bit. You know, we've done a couple of things together, and I think one led to a second, and now we're working on a third. So, you know, we have a little team working on some things, and you know, you're right in there, part of it. So maybe you could speak a little to that, how you did it as an M1.
Yeah, echoing Anna, I think the best thing you can do is figure out the question yourself and figure out the team that wants to work on it. I worked with, you know, now an M4, an M3, and 2 M1s, and we worked on just us doing a review of a very specific kind of injury, and there were no residents involved, so we could kind of just do it at our own pace, which ended up being pretty quick. But then the best thing you can do, I think, in getting started is just like Dr. Cott said, put your name out there. The thing that I did was show up to the tailgate, talk to Dr. Cott, put my name out there, say that I want to do research. He emails me that day with a project. And then that project led to another project, which might lead still to a separate project after that. So the foot in the door is really important. And if you want to get research, come up with your own question, and right place, right time, keep your name out there.
What else?
Now that step 1 is pass fail, and I know step 2 is gonna matter a lot more in terms of scores. Are there certain extracurricular things besides research that you as residents might be looking for, maybe in terms of like shadowing or conference experience or?
To be honest, I feel like obviously research is like probably the number one thing, and I don't know if I necessarily agree with that. I'm coming from a completely resident perspective. When we're doing our little interview rooms and we're meeting people and we tell people like, oh, we have no say, like that's never true, no matter anywhere you go, no matter what they say, because at the end of the day, if a resident comes up and says like, this person was really weird, the PD is going to listen to you, right? I would say like the thing that we just look for is just you being a normal human being, which sounds so plain and kind of like a pop-out answer, but it goes a long way. And you'd be surprised at how many people you go into an interview room and it's just super awkward and they like just don't seem interested and like have no questions and they have like no interest outside of medicine. Like we don't want to hear that you're like you do school really well, because everybody does. We want to hear that like you like did some really weird race underwater with like, I don't know, like I don't know, something super bizarre, because that's something like that's interesting. And like if you're passionate about it, like we'll go off of that. But like, I don't know, it's just like everyone, there's so many really great applicants these days, and it's just becoming more and more competitive. Like just being in a social situation and being able to be normal and having interests that are not medicine related, because like medicine related interests are cool, but they're super boring. And like so many people have them. I think the things that differentiate people are like having like good hobbies that people actually do. I think those are like when we're doing our little group meeting amongst the residents, like we're like, oh, that person was really cool. Like Matt, who was like a cowboy. We were like, Matt's a cowboy. That's really weird. Like we like him. Like let's pick him.
I get it.
Yeah, it was a little controversial. So maybe pick something a little bit less controversial.
What was weird about Ryan?
It's the same thing, everything.
Takeaway is you have to do an underwater race.
I'd also want to plug, and I both did the summer program, which was just like a week. I know you guys worked a lot on it. Anyone here or on the call, it was a really, really great experience. It's just a week. Long days, even for us. It was a really good experience into like what ortho actually looks like.
Honestly, it was a lot of fun. Like
And,
we
yeah.
had to be there at like, what was it? Almost like 5:30.
We were there for,
There was one day when we showed up literally 45 minutes early and we were just kind of sitting there. We were like, we were supposed to be here early, but that was fine. We were just like, this is the immersion. Yeah. So like, I thought if anyone's interested in doing that, I don't know if the deadline's passed already or not, but like I highly recommend doing it, because like from what I've heard about other programs is like you're just gonna get to do research and you might be on a team with like 15 people or so, right? And like you're kind of gonna be fighting to be that one like person to get something out of the experience. But here, because it's such a small group, it gets to be individualized and you really, really like get immersed in it and you get to see like all different areas of ortho. So I thought it was really beneficial. I learned a lot, and that also kind of like solidified for me that all right, it's 1 week where you have to be up at like 5:30 at the hospital at that time. Is that something that like you are interested in? And that's a good way for you to kind of see early on, are you going to be able to like apply yourself in that direction, and are you going to be able to like consistently motivate yourself to sort of like get up and be there.
Anything from you guys? Well, we good.
I think we're good, unless anyone on Zoom has a few questions.
But it looks like the chat is quiet, so. Yeah.
All right, so I think that's a good place to end it.
All
It's
right.
candy for us.
Yes.
Yes, it was. Thank you all for coming. Feel free to enjoy the candy. Thank you to everybody on Zoom. We did record it, so we will, send it out, make it available to everybody. And if you didn't do the attendance, just see me and I'll give you guys the QR code and form and whatnot. But thank you again. Thank you to our presenters. Another round of applause. They did a great job. All right. That's all.